Okay, now we are moving to a different subject, the intestinal ultrasound, to measure disease activity in ulcerative colitis. And the question, can that be of any use? When I talked to an IBD expert, naive in ultrasonography, about 3 years ago at ECHO, that colleague told me ulcerative colitis is a disease of mucosal layer and not a transmural disease, Christian, and intestinal ultrasound will be of no use for detecting activity or guiding the therapy of ulcerative colitis. However, that colleague has been wrong, or not wrong, but lots of data have since then evolved, and you can find a very nice systematic review by our Australian colleagues in JCC just published in May of this year. Now let's go into more detail. When to apply intestinal ultrasound in UC? 3 main areas: initial diagnosis, and I'm just going to touch upon it very briefly, monitoring therapeutic success and detect recurrence, and predict non-response due to fibrosis. Let's start with initial diagnosis. But before we start, the question is, what parameters do we actually look for in UC when we apply intestinal ultrasound? There are a few parameters less than in Crohn's disease. First, it's bowel wall thickness, and that's the main parameter, as you will see later on. Secondly, bowel wall stratification, bowel wall perfusion, hostration or loss of hostration, and maybe mesenteric proliferation, though we don't have too much data on that yet. Now, first, initial presentation. Let me start with an example. 24-year-old patient. She has bloody diarrhea 6 to 8 times per day for more than 2 months, abdominal cramping, no medical history. So if that patient presents to the emergency room or to your outpatient's clinic, the question is, what are you going to do next? A patient with more than 2 months of diarrhea certainly probably needs endoscopic examination, but there's not a spot available right away. So the question is, can you predict, or can you at least get an idea of the amount and the degree of inflammation? So the easiest thing, actually, if you have an ultrasound machine available, is performing an intestinal ultrasound. This is exactly what we have done. Now in that patient, you can see on the left side of the image the right colon with a normal bowel wall thickness of 2.9 millimeters, with normal bowel wall stratification, maybe a bit reduced hostration. On the left side, and the right side of the picture, but the left colon, you can see a severely thickened descending colon with 8 millimeters, abrogation of the stratification, and loss of hostration. So clearly in that patient, you can see that there is left-sided colitis. So the next question then would be, what could that be? Now, if your patient is Northern European, you have mainly 2 main causes. It could be infectious colitis, though 2 months of bloody diarrhea would be quite a long time, and initial manifestation of IBD, inflammatory bowel disease, and since it's left-sided colitis, ulcerative colitis. But clearly, your intestinal ultrasound is not proving, it just helps you guide your next diagnostic method. If you have instead a 73-year-old patient, same symptoms, acute bloody diarrhea 6 to 8 times per day for more than 2 weeks, abdominal cramping, medical history, heart insufficiency, diabetes, diverticular disease, the differential diagnoses are much more broader, like infectious colitis, ischemic colitis, diverticular-associated colitis, ulcerative colitis, colonic cancer, vasculitis, so much broader. But still, again, if you see a clear marked left-sided thickening of the bowel, you know that by sigmoidoscopy you could at least get a hint on what type of disease is underlying. But to be honest, there are not too many data on initial diagnosis and the use of intestinal ultrasound in UC. Much more important for daily routine is actually monitoring therapeutic success, detect recurrence, so actually activity detection. Actually, my co-chair more than 2 decades ago already looked at ultrasonographic evaluation of ulcerative colitis. He looked at 30 patients consecutively, and he found that UC correctly defined extension in 74% as defined by double contrast barium enema, The degree of bowel wall thickness significantly correlated with clinical and endoscopic activity, and in response to, at that time, steroids, bowel wall thickness decreased significantly in patients with clinical improvement and did not change significantly in patients showing no clinical improvement. Now that's a long time ago, methods have changed, but still you see it's nothing very recent. Colleagues have already looked at it more than 20 years ago. And here's an example from our clinic again, a 22-year-old patient with an acute flare of ulcerative colitis. You can clearly see on the bottom the sigmoid thickened 4.1 millimeters, intact bowel wall layers, and then the descending colon on top, 7.0 millimeters thickened, reduced haustration, still intact stratification. That patient was treated mid of January 2016 with an anti-inflammatory therapy, and then looked at again 6 weeks later, and you can clearly see on the bottom sigmoid back to normal 2.0 millimeters, descending colon back to normal 2.3 millimeters. So a clear response of bowel wall thickness in response to anti-inflammatory therapy. Very easy to detect and to follow up. Now what's more recent data? From 2011, 51 patients with moderate to severe UC looked at retrospectively. All patients with pathological bowel wall thickness of colon more than 4 millimeters, and the wall thickness correlated well with CRP, which is a bit surprising to me since often ulcerative colitis does not show any increased CRP, and endoscopic score. Now that's from 2011 and retrospectively. From 2014, now prospectively, 50 patients with suspected UC flare. They received a colonoscopy and an intestinal ultrasound, and the disease extent concordance was 90% compared to endoscopy. Intestinal ultrasound strongly correlated with clinical and endoscopic activity of disease. The intestinal ultrasound parameters with an independent predictive value of severity were increased thickness, increased vascularity, loss of haustra, and loss of stratification. That's a monocenter study. Another monocenter study more recently from 2018, 53 UC patients, 56% with left-sided colitis, 90% with pancolitis, were prospectively enrolled. 22 patients had mucosal healing, defined as a Mayo endoscopic subscore of 0 to 1. 31 patients were in endoscopic activity. Now, the change in GIUS parameters according to endoscopic activity, there was a significant correlation between Mayo endoscopic subscore and colonic wall thickness, colonic wall flow, hypoechogenic colonic wall pattern, and mesenteric lymph nodes. So, prospective study clearly showing a very good correlation between endoscopic activity and especially bowel wall thickness and colonic wall flow. Another more recent study from 2018 from Japan, 156 ulcerative colitis patients. The patients received intestinal ultrasound and colonoscopy within 2 days in 5 different centers. So that's already a multi-center study, not prospective, but it's just one time point. The intestinal ultrasound severity was graded 1 to 4, and counted was the bowel wall thickness, stratification, and ulceration. And the colonoscopic severity was graded 1 to 4 according to Metz endoscopic classification, which is not a very common score that we use in Europe. The colleagues in Japan were able to show moderate concordance rate for each segment, except slightly for rectum, and the intestinal ultrasound grade significantly correlated with the activity on endoscopy and histological grade. And they summoned that intestinal ultrasound may be used more generally for evaluation of UC in daily clinical practice. So we have several single center studies, one with now 5 centers, showing that intestinal ultrasound could be very useful. Now, how about in broad range of centers at the same in a multi-center study prospectively evaluating the use of intestinal ultrasound? This is now a study from our own group performed in Germany with the aim of prospective evaluation of intestinal ultrasound for follow-up controls in ulcerative colitis patients routinely in daily medical practice. More than 40 German IBD centers participated in that study, and the inclusion criteria was patients with known left-sided or pancolitis with an acute flare, defined as SCCAI of 5 or more. The patients at baseline only had to have a clinical flare, and then intestinal ultrasound was performed, and only those with actually bowel wall thickened, defined as more than 3 millimeters in all segments except the sigmoid, in which the thickness needed to be 4 or more, could then continue for later visits. Let me show you first the documented population. So 253 patients were initially included. 25 were taken out or stopped after baseline since no increased bowel wall thickness was detected. 228 continued. 1 was withdrawn because of Crohn's disease diagnosis 2 weeks later, and 3 actually the bowel wall thickness could not be determined in complete extent. So the analysis population was 224, so a very large number of patients prospectively evaluated. Left-sided colitis in 112, pancolitis in another 112. Now some of the findings. Proportion of patients with increased bowel wall thickness. You can see in the left side that 90% had a thickened sigmoid and almost 90% is a thickened descending colon, defined as more than 4, and for the descending more than 3 millimeters. And you could see already at week 2 a significant decrease in bowel wall thickness in both segments. So very rapid response of bowel wall thickness in response to anti-inflammatory therapy, and the type of anti-inflammatory therapy was due to the discretion of the investigator. So various drugs were used. You can see very quick response of bowel wall thickness already at week 2. You can see there's not too much more change at week 6 and at week 12. Proportion of patients with increased color Doppler signal on the right side. You can see that there's already a nice response at week 2, but there was more pronounced signal at week 6 and at week 12. We also looked at different other parameters: loss of frustration, loss of bowel wall stratification, ascites, mesenteric lymphadenopathy, and mesenteric fibrofatty proliferation. You can see all parameters significantly decreased in response to therapy, but again, the most pronounced change was bowel wall thickness, already significant at week 2. So at a very early time point that you can actually follow up patients where you perform anti-inflammatory therapy. You could never do an endoscopic follow-up at 2 weeks or even at 6 weeks, but ultrasound you can see a very early response, and now future studies will have to detect if this, looking at this early time, but you can really predict who is on the right medication, where do you have to intensify medication, or where could you maybe at a very early time point already change the type of therapy. Now the question is, how good are we actually with the Interobserver agreement of our parameters? So in a study, a multicentric cross-sectional prospective study, 5 gastrologists with high expertise in intestinal ultrasound and an IVD were blinded to clinical status of the patient and blinded to the outcomes of the other readers. All received the same number of video loops of prospectively collected data from patients with ulcerative colitis, and was performed, as you can see, by various investigators from various countries from the International Bowel Ultrasound Group. The Interobserver agreement for the presence of disease activity on intestinal ultrasound was substantial. Disease severity was almost perfect, and per ultrasonographic parameters, you can see for bowel wall thickness and for Doppler signal very good kappa values and significant, and especially agreement perfect, good, and the moderate for inflammatory fat, while lymph nodes and loss of stratification were only fair. But the most important parameters, bowel wall thickness and Doppler signal graded as absent versus present, was perfect. Doppler signal graded in various categories, and we know that from other trials was more moderate. But if you use bowel wall thickness absent less than 3 millimeters, present equal or more than 3 millimeters, or Doppler signal absent versus present, you get perfect Interobserver agreement. Now, Interobserver agreement seems to be, at least for those parameters, perfect to good. The next question is, do we actually have a score for assessing disease activity? And Stephen Botts and colleagues from the Amsterdam group, they developed an intestinal ultrasound ulcerative colitis score, which considered bowel wall thickness, Doppler signal, loss of hostration, and presence of fatty wrapping, and the global GIUS score showed high correlation with overall endoscopic disease activity. However, they concluded that this needs to be validated in future prospective studies, and I have to mention that this so far has only been published as an abstract at ECHO 2018. Full publication is yet pending, and this score has not been evaluated in future prospective studies yet. But clearly, a clear score would be very helpful for daily routine and especially for clinical trials. Now, how about echo? I told you that about 3 years ago, an expert on IBD at echo told me, oh, the use of intestinal ultrasound is not very helpful in ulcerative colitis. But if you look at the most recent ECHO-ESCA diagnostic guideline, you can clearly see that colonoscopy is the modality of choice to assess disease activity of symptomatic colonic Crohn's disease or UC, and cross-sectional imaging is complementary to assess phenotype and may be used as an alternative to evaluate disease activity. Sigmoidoscopy should be considered in UC if symptoms suggest an acute severe flare, but again, as you can see in the statement, cross-sectional imaging such as intestinal ultrasound is also a valid method. Now, something very recent publication is looking at the difficulty of assessing disease activity in the rectum, as we know that proctitis can be challenging. And that's again from the Japanese group, just published in June. Transperineal ultrasound predicts endoscopic and histological healing in ulcerative colitis, and they looked at 53 consecutive adults with UC who required colonoscopy, and they received transperineal ultrasound together with transabdominal ultrasound within a week before or after colonoscopy with rectal biopsy, and for endoscopy the myoendoscopic subscore was used. And just quick overview, and I won't go into detail as this is not the major aspect of this talk. They found with a logistic regression analysis for predicting rectal endoscopic activity an odds ratio for bowel wall thickness transperineal ultrasound of 4.21 and for bowel wall flow of 13.78, both being significant. So maybe this could be a future potential method for patients with just proctitis, but in daily routine, transperineal ultrasound is rather challenging for disease follow-up as daily routine. Now, lastly, predict non-response due to fibrosis. So can we actually predict or say, okay, there is no activity, there is no use of using further anti-inflammatory drugs? Now, here's an example of a patient not responding to anti-inflammatory drugs, and that an endoscopy did not show any significant inflammation. You can see loss of stratification. There is intact bowel wall layers, but the submucosa is thickened. I'll show you again. So no hostration, intact bowel wall layers, and you do hostration. And that's a typical picture you find in patients with fibrosis, patients who often still present with symptoms of diarrhea, but that's more due to non-functioning of the large bowel and not due to inflammation. Now, do we have any valid parameters to measure? And there are only very small studies. 11 patients with contrast enhanced ultrasound CRP endoscopy with biopsy, and that study showed a strong negative correlation between the ratio time to peak. So very small study, no conclusive results. Another one with a few more patients in 2015, 67 UC patients, and 25 of them were followed up. And the tick in the AUC correlated better with endoscopy than clinical score, and the area under the curve was the best predictor for endoscopic improvement. But again, single center study is very small, and there hasn't been much more published in more recent. Another thing that Gianni touched upon in looking at fibrosis is the elastography. So in this study, 37 UC patients, colonoscopy and real-time tissue sonal elastography. The colleagues did find a difference in those with endoscopic activity and no endoscopic activity. But again, just one study, single center, just a few patients, and nothing where we can really at this time say that elastography helps us in differentiating. So detecting and measuring fibrosis is an evolving area of research. There's lots that needs to be explored, and I think for future trials and for future treatment, that's very important to clearly define fibrosis using intestinal ultrasound. A few things to keep in mind. Firstly, patients 38 years old, ulcerative colitis since 2008, clinical acute flare. And the question is that left-sided colitis? And you always have to keep in mind you can see inflamed bowel, but you can't differentiate acute infectious colitis from a flare. And this patient actually had a salmonella infection plus an acute UC flare, so never make the diagnosis just from intestinal ultrasound. It's always one part of the clinical assessment, but you can't just focus only and solely on intestinal ultrasound. Second thing I already said before, 21-year-old patients, known UC, bloody discharge 6 to 8 times per day, normal intestinal ultrasound, but the rectum could not clearly be shown, and the patient had a severe proctitis, only the last 3-4 centimeters involved, could not be seen by transabdominal ultrasound. So a normal intestinal ultrasound doesn't mean there isn't any inflammation. So if there is a discrepancy, you always have to consider doing endoscopic ultrasound, endoscopy as well. So careful, proctitis can be easily missed by intestinal ultrasound. Another thing, 65-year-old patient with long-term ulcerative colitis. If you look at the descending colon on the left side, you see that there is very darkish bowel wall, no stratification, so it looks like severe inflammation, but actually the patient didn't have lots of inflammation, was lots of pseudopolyps. So pseudopolyps can sometimes be very tricky. You cannot always see the pseudopolyps. In this patient, you actually can see the pseudopolyp right here on the left side, the mass that you see in the middle of the image, and that's the endoscopic picture. So pseudopolyps can sometimes make the picture a bit more difficult. So if you see thickened bowel, please always keep in mind if that's a long-term ulcerative colitis, you might have lots of pseudopolyps. And last example, 34-year-old patients with ulcerative colitis since 2009. The patient presented in 2016 with an HB of 8, CRP highly elevated. You can see that there is thickened bowel wall, so it could be a flare. But if you look at the video image, I'll start that, and you clearly look, the bowel wall layers actually look a bit different. You see the muscularis area is thickened. It's more the outer layers that are darkish and thickened, and that actually was a lymphoma in the ascending colon. So if you see thickened bowel, it doesn't always mean that there is increased inflammatory activity, but if you see that there's a different kind of bowel wall layers, always consider differential diagnosis. This patient, in addition to the lymphoma in the right colon, also had a rectal carcinoma, which could not be seen by ultrasound. Now, in conclusion, intestinal ultrasound to detect disease activity in UC, yes, it is very helpful. Nothing is 100% sensitive and specific, but bowel wall thickness colored duplex in patients that have an acute flare where you see thickened bowel is a very good parameter to monitor, and you can see it in a very short term, 2 to 3 to 4 weeks, if a patient responds or doesn't respond. But still, lots has been studied in more recent years, but there are still many areas, including an activity score, fibrosis detection. So those of you who are interested in getting funds for research, there's an ECHO IBIS Research Grant for 2020. The submission is open. The application deadline is August 31st, 2020. And if you go to the website www.ibus-group.org, you can find all the details on the grant application, and we are more than happy to receive many good applications. So with this, I want to thank you for your attention, and I'm more than happy to answer any questions.